Constipation S. Mimi Mukherjee, Pharm D, BCPs, CDE Sandra Marwill, MD, MPH Basics Unsatisfactory defecation characterized by infrequent stools, difficult stool passage, or both. Characteristics include love, bowel movements a week, hard stools, excessive straining, prolonged time spent on the toilet, a sense of incomplete evacuation, and abdominal discomfort/bloating. Description system, S. Affected, gastrointestinal, GI, synonym, S. Obstipation. Geriatric considerations. Colorectal neoplasms may be associated with constipation. Consider new onset constipation after age 50 years a red flag. Use warm water enemas, instead of sodium phosphate enemas, for impaction in geriatric patients. Sodium phosphate enemas have been associated with fatalities and severe electrolyte disturbances. 1. Pediatric considerations. Consider Hirschsprung disease, absence of colonic ganglion cells, in cases of pediatric constipation. Hirschsprung disease accounts for 25% of all newborn intestinal obstructions and can present as milder cases diagnosed in older children with chronic constipation, abdominal distension, and decreased growth. Hirschsprung has a 5:1 male to female ratio and is associated with inherited conditions, e.g., Down syndrome. Pregnancy considerations. Avoid misoprostol. Epidemiology more pronounced in children and elderly. Predominant sex, female male, 2:1, non-whites. Whites incidence 5 million office visits annually. 100,000 hospitalizations. Prevalence 16% of adults greater than 18 years, rising to 33% of adults greater than 60 years of age. 3% of pediatric visits relate to constipation. Etiology and pathophysiology. As food leaves the stomach, the ileocecal valve relaxes, gastroileal reflex, and chyme enters the colon, 1 to 2 L/day, from the small intestine. In the colon, sodium is actively absorbed in exchange for potassium and bicarbonate. Water follows the osmotic gradient. Peristaltic. Contractions move chyme through the colon into the rectum. Chyme is converted into feces, 200 to 250 ml. Normal transit time is 4 hours to reach the cecum and 12 hours to reach the distal colon. Defecation reflexively follows as stool reaches the rectal vault. This reflex can be inhibited by voluntarily contracting the external sphincter or facilitated by straining to contract the abdominal muscles while voluntarily relaxing the anal sphincter. Rectal distension initiates the defecation reflex. The urge to defecate occurs with an increase in rectal pressure. Distension of the stomach also initiates rectal contractions and a desire to defecate, gastrocolic reflex. Primary and secondary defecation disorders result from delay in colonic transit, altered rectal motor activity, and structural or functional problems with pelvic floor muscles, including paradoxical contractions, diminished sphincter relaxation, and or poor propulsion. Genetics unknown but may be familial. Risk factors: very young and very old, polypharmacy, sedentary lifestyle or condition, improper diet and inadequate fluid intake, general prevention, high fiber diet, adequate fluids, exercise, and training to obey the urge to defecate. Commonly associated conditions: general debilitation, disease or aging, dehydration, hypothyroidism, hypokalemia, hypercalcemia. Nursing home resident. Diagnosis: alert red flags. New onset after age of 50 years, hematochezia/melena. Unintentional weight loss, family history of colon cancer, anemia, neurologic defects. History: assess onset of symptoms, number of bowel movements per week, straining, completeness of evacuation, and use of manual manipulation. Identify red flags, evaluate diet, lifestyle, prescription, and OTC medication use. Identify reversible causes. Ask about history of sexual abuse, opioid use. Bristol Stool Form Scale. 7 categories of consistency. 2. A diary of dietary intake and bowel patterns helps to measure treatment response. Rome 3 criteria. At least 2 of the following for 12 weeks in the previous 6 months. Love, stools per week straining at least 1/4 of the time, hard stools at least 1/4 of time, need for manual assist at least 1/4 of time, sense of incomplete evacuation at least 1/4 of time, sense of anorectal blockade at least 1/4 of time, loose stools rarely seen without use of laxatives, frequent constipation but does not meet irritable bowel syndrome, IBS, criteria. Although there can be overlap, the history of primary constipation differs from constipation predominant IBS. In primary constipation, pain and bloating are relieved by adequate defecation. In IBS, pain and bloating predominate and are not readily relieved by defecation. Bowel Function Index for opioid-induced constipation, OIC, score of 0 to 100, mean of 3 variables, ease of defecation, completeness of emptying, patient's rating of constipation severity, physical exam, vital signs, abdominal exam, previous surgical scars, hypoactive bowel sounds, tenderness, and masses, gynecologic exam, evaluate for masses and rectocele. Digital rectal exam, evaluate for masses, pain, stool, fissures, and hemorrhoids, assess sphincter tone. Neurologic exam, differential diagnosis, primary constipation, primary problem is within the GI tract, has 4 subtypes. Normal colonic transit time, most common subtype, can be difficult to differentiate from constipation predominant IBS. Slow colonic transit time, pelvic floor/anal sphincter dysfunction, combination pelvic floor/anal sphincter dysfunction and slow transit. Secondary constipation, outside the GI tract, endocrine dysfunction, diabetes mellitus, hypothyroid, metabolic disorder, increased calcium, decreased potassium, mechanical, obstruction, rectocele, pregnancy. Neurologic disorders, Hirschsprung, multiple sclerosis, spinal cord injuries, Parkinson disease, congenital Hirschsprung disease/syndrome, hypoganglionosis, congenital dilation of the colon. Small left colon syndrome. Medication effect, opioids, antidepressants, antipsychotics, antacids, calcium, aluminum, non-dihydropyridine, calcium channel blockers, especially verapamil, iron and multivitamins with iron, diuretics, overuse of antidiarrheal medications. Diagnostic tests and interpretation, identify red flags, secondary causes, and reversible conditions. If none present, go to first-line treatment. Initial tests, lab, imaging, CBC to screen for iron deficiency anemia. Consider tox screen if illicit opioid use is suspected. Calcium, glucose, and thyroid function testing, TSH, based on history and exam. If red flags are present, refer for sigmoid/colonoscopy. Follow-up tests and special considerations for patients with pelvic floor dysfunction or exam abnormalities, e.g., rectocele and/or patients who are refractory to initial treatment, refer to an experienced subspecialist. A physical therapist experienced in biofeedback can also be very helpful. Diagnostic procedures/other anorectal manometry, ARM, balloon expulsion testing, BET, scintigraphy, MRI, defecography, colonic marker studies. Test interpretation, ARM and BET recommended for all refractory cases. If ARM and BET are negative, scintigraphy may help evaluate transit time. Consider biofeedback prior to scintigraphy. Treatment, address immediate concerns, bloating/discomfort/straining, osmotic agents postoperative, after childbirth, hemorrhoids, fissures, stool softener to aid defecation if impacted, manual disimpaction, and then treat any underlying conditions. General measures in patients with no known secondary causes, conservative non-pharmacologic treatment is recommended. Eliminate medications that cause constipation. Increase fluid intake. Increase soluble fiber in diet. Encourage regular defecation attempts after eating. Regular exercise. Enemas if other methods fail. Avoid sodium phosphate enemas in geriatric patients. 1. B medication. Non-prescription medications are first line. If patient goals are not reached, advance to prescription medications. First line bulking agents, accompanied by adequate fluids. Hydrophilic colloids, bulk forming agents, psyllium, consul, metamucil, Per diem fiber 1 tablespoon in 8-ounce liquid PO daily up to TID methylcellulose. Citrusol 1 tablespoon in 8-ounce liquid PO daily up to TID polycarbophil. Mitrolin. Fibercon 2 caplets with 8-ounce liquid PO up to QID stool softeners docusate sodium. Colase 50 to 100 mg PO TID osmotic laxatives polyethylene glycol. PEG. Myra LAX. 17g/day PO dissolved in 4 to 8 ounces of beverage. Current evidence shows PEG to be superior to lactulose. 3. B-lactulose, granulac, annulose. 15 to 60 ml PO QHS. Flatulence, bloating, cramping, sorbitol. 15 to 60 ml PO QHS, as effective as lactulose. Magnesium salts, milk of magnesia 15 to 30 ml PO once daily, avoid in renal insufficiency. Second-line stimulants, irritate bowel, causing muscle contraction, usually combined with a softener, work in 8 to 12 hours. Sena/docusate, Senecot S, X-Lax, Pericolase 1 to 2 tablets or 15 to 30 ml PO at bedtime. Bisacodyl, Dulcolax, Correctol 1 to 3 tablets PO daily. Lubricants, soften stool and facilitate passage of the feces by its lubricating oily effects. Mineral oil, 15 to 45 ml/day, short-term use only, can bind fat-soluble vitamins, with the potential for deficiencies, may similarly decrease absorption of some drugs. Avoid in those at risk for aspiration, lipoid pneumonia. Suppositories osmotic, sodium phosphate lubricant, glycerin stimulatory, bisacodyl enemas, saline, fleet enema, lobiprostone, amatiza a selective chloride channel activator, 24-μg PO bidprocollopride, motgridia serotonin 4 receptor antagonist, adult dose, 2 mg PO once daily, for CRCL30 use 1 mg once daily, increased incidence of suicidal ideation reported in clinical trials. Guanylate cyclase C agonists, adult use only, linaclotide, LINS dose, 145 μg PO once daily, can use lower dose 72 μg once daily. Pleconatide, Trolins dose, 3 mg PO once daily. Peripherally acting mu-opioid receptor antagonists, indicated for OIC. Try laxatives first. Lobiprostone also approved for OIC. Methylnaltrexone, Realister dose, 38 to 62 kg, 8 mg, 62 to 114 kg, 12 mg SC every other day. PRN naloxegol, Movantik dose, 12.5 to 25.0 mg PO daily. Discontinue other laxatives for 3 days when initiating naloxegol. Avoid in patients on strong CYP3A4 inhibitors due to increased naloxegol levels and risk of opioid withdrawal. Naldimedine, Simproic dose, 0.2 mg PO daily. Monitor for opioid withdrawal in patients on strong CYP3A4 inhibitors or PGP inhibitors. Prokinetic agents, partial 5-HT4 agonists, have been withdrawn due to cardiac side effects, only available via IND protocols. Take Acerod, Zelnorm, Cisapride, Propulsid. Other agents not approved by the FDA, misoprostol, cytodica prostaglandin that increases colonic motility. Colchicine, neurogenic stimulation to increase colonic motility. Additional therapies. Other non-pharmacologic therapies include biofeedback, a first-line recommendation for patients with refractory constipation due to functional conditions involving dyssynergic defecation or inadequate propulsive force. Behavior therapy. Acupuncture, initial randomized trial effective at 20 weeks, longer-term trials needed. 4. B. Surgery/other procedures. Surgery rarely indicated, sometimes required for anatomic findings, rectocele or enterocele. Admission, inpatient, and nursing considerations. Toxic megacolon manual disimpaction occasionally required in chronic refractory cases. Ongoing care. Follow-up recommendations encourage exercise and physical activity. Patient monitoring. If functional constipation persists, revisit secondary causes. Diet. Increase soluble fiber. Bloating and gas can be problematic with insoluble fiber. Gradually increase intake to 25 g/day over a 6-week period. Oat bran, Hard outer layer of cereal grains, peas, onions, lentils, beans, seeds, nuts, and fruits, including bananas, apples, and strawberries, encourage liberal intake of fluids. Patient education. Occasional mild constipation is normal. Bowel training. The best time to move bowels is in the morning, after eating breakfast, when the normal bowel transit and defecation reflexes are functioning. Prognosis. Occasional constipation responds well to simple measures. Habitual constipation can be a lifelong nuisance. Patients with neurologic compromise can suffer from obstipation, impaction, and toxic megacolon. No evidence for laxative dependence or harm from stimulant use. Melanosis coli may develop but is a benign condition. Complications. Volvulus toxic megacolon. Acquired megacolon in severe, long-standing cases. Fluid and electrolyte depletion, laxative abuse. Rectal ulceration, stercoral ulcer, related to recurrent fecal impaction. Anal fissures. References 1. Ori